Hey folks, I'm Scott Weingart, and this is the EMCrit podcast. Today on the podcast, something I am incredibly excited about. There is a new trial that has been under embargo, but I was lucky enough to have early access to it, that has really validated things I have been saying for the past 15 years, since the very beginning of EMCrit, and it is the PREOXI Trial. And if you are listening to this right now, it means the embargo has been lifted, and I could finally talk about the results. And this trial was really superb. I think it is a practice-changing paper. And what happened is the Pragmatic Critical Care Research Group wanted to look at non-invasive positive pressure ventilation preoxygenation versus standard preoxygenation. And we're going to discuss that trial in the course of this podcast. I'm going to really go through the trial and its results, and then I'm going to talk to the lead authors, Kevin Gibbs and Adit Gindi, about their feelings about the paper, and they will simultaneously be in Ireland at the Critical Care Reviews Conference, debuting their work. And then I'll talk about some of my recommendations based on all of my accumulated thoughts on preoxygenation and how this paper ties into them. So that's what you're in store for very shortly. Before we get to that, we still have tickets on sale for the Reanimate Resuscitative ECMO Conference, November 2024 in San Diego. And you've heard enough about it that you know what it is. Buy the tickets because they're selling out. You can find that at reanimateconference.com. Let's get right into the paper. So this came from the Pragmatic Critical Care Research Group, the group that is just doing so many amazing trials in critical care. And specifically, they are putting out large, incredibly well-performed trials in airway and the device trial, all of these amazing trials. It's just such a heyday for airway research. And they're getting published in the best journals. I don't even know what journal this paper is going to go to. I didn't ask. It was technically a secret. So it's going to be in some prestigious, top-line journal. So let's go through the paper, the PREOXI paper, and then we'll talk to its lead authors. So using the PICO format in terms of patients, this was a multi-center RCT in 7 emergency departments and 17 ICUs spread across the USA. And it was a study in adult patients, and they couldn't be apneic or being bagged or a crash intubation such that they could not get randomized into the trial. 48% of them, nearly half, were hypoxemic respiratory failure. And 73% of the intubations were in ICU, and 27% were in ED. So about 3/4 ICU, 1/4 ED. So what were the interventions? Now, this was a pragmatic trial. Now, what that means for people not familiar with this evidence-based medicine type stuff is that they made a tiny little difference between the groups in the randomized control trial, but everything else was as per standard care. And so the difference in the intervention group was that they asked that whenever possible, patients were placed on non-invasive positive pressure ventilation for their preoxygenation. And what did this mean? It means they either had a ventilator or a BiPAP, a non-invasive positive pressure machine, in the ideal circumstance. And they were put on an FiO2 of 100% by recommendation. Again, none of this necessarily had to happen because it's whatever the exigencies of the moment, but this was the recommendations. 100% FiO2, a EPAP, an expiratory pressure of at least 5, so 5 or greater, an inspiratory pressure of greater than equal to 10, which to translate that would be a PEEP of 5 or greater, and then a pressure support of 5 or greater above that, a respiratory rate of greater than equal to 10. So essentially, these patients were being put on what in essence is an SIMV mode for their preoxygenation. And then that was continued during the apneic period in most of the patients. So you just keep on those same settings. So then essentially what was happening is a combination, a bundle, if you will, of 5 things in the intervention group. There was high FiO2 preoxygenation, as close as you could get to 100%. There was PEEP or CPAP preoxygenation, right? That was built in. Now, this one was there. I don't think it mattered in terms of the preox, but there was an inspiratory pressure in the preoxygenation as well, because this was a BiPAP mode, not a CPAP mode. Then once the patient was induced, there were apneic breaths being given because you had this rate of at least 10. And then there was apneic PEEP or apneic CPAP, if you will, such that these patients were going to have an increased mean airway pressure during their apneic period. So 5 things were essentially happening, all bundled into one in this intervention group. Now, 95.5% of the patients actually got non-invasive positive pressure ventilation preoxygenation. And there was reasons in the supplement you could see why some of them missed it. Only 0.6% of the patients couldn't tolerate it, which is of interest, right? Because, for me, if I felt this was necessary, and you'll shortly see that I feel it's necessary in any critically ill patient, I would have been giving them ketamine to tolerate it. That was not done in this trial. So the ones that couldn't tolerate it, it was less than 1% couldn't tolerate non-invasive positive pressure ventilation preoxygenation. And of note, 3% of these patients got a nasal cannula in addition to their non-invasive positive pressure ventilation. And then a recommendation was given for a jaw thrust during the apneic period so that they would actually get these breaths to go in and not just hit a closed glottis or posterior airway structures. So that was the intervention group. What was the comparator group? The comparator group was non-rebreather mask was the recommendation. And it was recommended that it was greater than equal to 15 liters per minute, but with a strong instructive emphasis on the fact that flush rate oxygenation, and since this is the USA, that means turning the flow meter all the way up such that these patients could be getting upwards of 50 liters per minute, was strongly emphasized. And in fact, the folks who did the flush rate work were part of the trial group, and 98.8% of the patients got their non-rebreather mask. And again, for that other 1.2%, you could see the supplement of the paper to find out why they didn't. Now, 30% of these patients got BVM with ventilations during the apneic period, so getting apneic breaths. 11.3% got a BVM placed during the apneic period without ventilations. We don't know in either of those, the 30 or 11.3% groups, how many of them had PEEP valves on their BVM. Unfortunately, that was not a piece of data that was collected. And 16% of them had some form of nasal cannula, whether it be high flow or regular nasal cannula. All right, what was the outcome? This was analyzed in an intention to treat fashion, meaning even the patients who didn't get the non-invasive positive pressure preoxygenation were still treated as if they'd had for the analysis of the outcomes. So if it was an actual received therapy, the results potentially could be even better. But even with that intention to treat analysis, the rate of hypoxemia, which was defined as less than 85%, either during the induction or up to 2 minutes after the intubation, was 9.1% in the intervention group and 18.5% in the standard care group, which means that you had half the risk of hypoxemia from a relative risk potential. That's enormous. Number needed to treat, about 10 to avoid one case of hypoxemia less than 85%. Cardiac arrest, 0.2% in the non-invasive group, 1.1% in the standard group. So 5 times the risk of cardiac arrest peri-intubation. Aspiration, a safety outcome. No difference, no significant difference. And in fact, the actual point estimates were higher in the standard group. This is a fear people have with this non-invasive during pre-induction and during induction, during the apneic period, is they're going to aspirate. They won't. And this is not just CPAP. This is not just PEEP. This was actually giving them positive pressure breaths. So it goes along with the results of the PREVENT trial in that sense. The saturation less than 80% from induction to 2 minutes post-intubation. So even lower. This is what we consider the critical threshold of hypoxemia. 6.3% in the non-invasive group, 13.2% in the standard group. So again, double the risk in standard preoxygenation. So that's the trial results. I have so much more to say about this, but why don't we segue into talking to the lead authors about some clarifications and their thoughts about the study, and then I'll finish it up with my recommendations going forward. The first question I'll ask both of you is the question I ask everyone. Who are you and what do you do? We'll start with Kevin just because that's his location on my screen.
Excellent. Hey, I'm Kevin Gibbs. I'm an intensivist in Wake Forest in Winston-Salem, North Carolina, and I do a mixture of ICU and clinical trials.
And I'm Adik Ginde. I'm an emergency medicine physician, professor and vice chair for research at University of Colorado, and acute and critical care trialist.
All right. And you two are on the author list of a incredible study that this will be just released. We've been embargoed up until now. And so it's the PREOXI study. Maybe one of you could tell me why you decided to make this happen.
Yeah, I'm happy to talk a little bit about that. Intubations in the ED and ICU are high-risk procedures, and complications are pretty common, occurring in up to about 20% of patients getting intubated. And one of the most common complications is hypoxemia, and hypoxemia increases the risk of really bad outcomes like death. And preoxygenation is probably the most important intervention to reduce the risk of hypoxemia. And additionally, there is limited data suggesting that non-invasive ventilation may reduce the risk of hypoxemia. 2 small studies were published, but they had conflicting results. So we pursued the PREOXI study to really be the definitive trial of non-invasive versus phase mask preoxygenation in the ED and ICU setting.
What I'd like to do is a little bit of clarification on the study, and then we'll talk about some hypotheses about what was found and why, and then what we should do with that information. So I guess the first one I would say is, and this was a pragmatic trial, so it's completely understandable why, but we're left with a number of different possibilities for why this had such a beneficial effect. And so the context is we were blending CPAP preoxygenation, high FiO2 preoxygenation, apneic CPAP, and apneic ventilation. All of those were in the mix between the non-invasive group and the standard group. And I'm going to give this question to both of you. If you had to pick one of them, of those various potential causes for benefit, which one do you think made the most difference? Or you just can't figure it out amongst that mix? We'll start with you, Adit.
Yeah, I think that by the pragmatic nature of the trial, we're trying to do real world implementation. These are real decisions that need to occur at the bedside in the trial, but also when implementing the result. I think it's a package deal. It's going to be different for each patient. We had for the intervention group that was quite strongly beneficial at preventing hypoxemia. The standard was non-invasive ventilation by BiPAP for at least 3 minutes. So that is the target. But different ways of implementing it are going to be impacted by individual patient characteristics. And so I think that's how we think about the results. There were times where there was a nasal cannula or a high flow nasal oxygen device used with the BiPAP. There were times where there was not enough time to set up the ventilator to deliver non-invasive ventilation. And so it was allowed to actually give a bag valve mask with positive pressure. The key is giving the ventilation, giving the positive pressure ventilation, and the intervention was the key feature of that distinguished the intervention group from non-ventilation high flow oxygen. Kevin, what do you think?
Yeah, I think I agree. It's really hard to tease apart the components of the intervention. But the thing I would highlight is I don't think this is just the positive pressure ventilation after induction, because our group has actually looked at that in the past. There was a study that came out in 2019, which showed that post-induction positive pressure reduced hypoxemia. But in this trial, we looked at that and we found that the likelihood of a patient receiving positive pressure via bag mask in the control arm did not change the benefit of non-invasive. Even if someone was likely to receive bag mask ventilation after induction, if they were in the oxygen mask group, that same hospital, when they were delivering non-invasive ventilation, had reduced hypoxemia. So I think it really is the package deal of non-invasive that provides the benefit and not just a single component.
Yeah, that's fair. Though, and this is where we start to really tease things out, I don't think it's the positive pressure during the apneic period that matters. I think it's the provision of increased mean airway pressure. And we don't know from the trial, were these BVM with PEEP valves? And if they did have PEEP valves, were the PEEP valves actually put to some level of PEEP beyond ZEEP? Because that would be a question I really have, is were the people getting BVM during their apneic period actually just having that for FiO2, or was there provision of some form of CPAP in the patients who did have BVM?
We didn't protocolize that and we didn't record that, so we really don't know.
Yeah, we left it up to usual care at that point. The intervention was really prior to induction, and then we recorded some elements of what happened from induction to laryngoscopy, and particularly the first couple minutes after successful intubation through that period. And we left it up to the provider in the usual care practice.
No, that makes sense. On similar theme, the training materials said that if you're going to use a face mask, a non-rebreather mask effectively, it should be at flush rate, but then said greater than equal to 15 liters per minute. Now, those are two very different things. And since these were all North American hospitals, you could have told people, open up the dial on your flow meter until it doesn't turn anymore, which would have given people greater than 50 liters, which we now know actually is a source of good FiO2, while 15 liters is grossly inadequate. I guess the question I'd have is, first, why didn't you just tell them during the training materials, open up as wide as possible? And then do you think, because I know what the doubters are going to say, the doubters are going to say you were just giving better actual preoxygenation than denitrogenation in the non-invasive group because they got 100% FiO2, while the non-rebreather group, if most of them were getting 15 liters, where it's only getting about 0.6 FiO2, is that where most of the benefit is?
I can go first on this one. I think this is somewhat of a philosophical question. First off, the authors on the flush rate papers were actually part of the study. I mean, they were involved with the study design. So we spent a lot of time discussing this, but this is one of the beautiful things about this network and the trials we conduct is that they reflect real world practice. And so the patients who received bag mask or non-rebreather preoxygenation received the intervention that they would if they were not part of the study. And at least in my institution, we spent a lot of time counseling flush rate oxygen delivery. So people could choose not to do that. Probably reflects what they do for the majority of their intubations.
Yeah, in the training, we had central training materials, and then there was the local implementation of the training. And there was definitely an emphasis on flush rate oxygen being optimal. And that was emphasized in both the central and the local training. That being said, do we make it a protocol deviation? Should they choose not to do that in their practice? No. This is a pragmatic trial, but it is something that was emphasized, and we were attentive to it in the trial.
Okay, so I won't hold you to that, but your feeling is that most of the people probably were giving reasonable preoxygenation in the standard group, that they were getting flush rate. At least that was something strongly urged. So we should feel that the difference really is not in the provision of FiO2 of non-invasive, that it actually is the positive pressure. Is that your feelings?
I think that's our experience from our individual sites and talking with the investigators and the teams that were implementing it, is that I think some of the practice on face mask oxygenation changed during the course or because of the trial, because of the increased emphasis on flush rate. But in many places, that was the standard already.
Makes sense. Kevin, anything to add to that before we go into the next question?
No, I'm pretty comfortable that any differences in FiO2 delivery were due to the natures of the interventions, and people were receiving the maximal oxygen they could from the non-rebreather or the bag mask device.
Why inspiratory pressure on the non-invasive group? It doesn't bring much to the table in terms of oxygenation, maybe an augmentation of ventilation, but that wasn't really what we were looking for in this trial. And there was no real signal for aspiration. So I don't really think we have to worry that it was topping off the esophageal sphincter. So I feel very safe on that. And that's one of the beauties of this trial, as I think it demonstrates the safety. But why was it even there? What was the thinking of why inspiratory pressure would be added to the non-invasive group?
I think the strongest rationale is that the simplest intervention, the better. I think you're right. The majority of spontaneously breathing patients who are getting preoxygenated do not require any inspiratory augmentation. But asking someone to either transition to another device after preoxygenation or adjust the ventilator to deliver apneic breaths, I think all of those things just increase the complexity of the intervention and make it less feasible. I mean, I think the nice thing about our study is that when you're performing preoxygenation, you set up the ventilator, you set your inspiratory pressure and your expiratory pressure, you set a backup respiratory rate, and then you get ready to intubate and you induce and you leave the mask on until you're ready to perform laryngoscopy, and then you go. And that's pretty appealing to me.
I like that idea of not having to transition to a different mode during the apneic period, or even ostensibly, you could just put them on to the vent immediately after the intubation. For that, you might want to make some adjustments later on, but it really does lead to an ease of use. This was a question I was going to ask later, but I think it's worthwhile now because it's apropos. So this in an ICU is not really a big ask in some places where they have vents at every bedside, but in other ICUs and in many EDs, this would require bringing a device to the bedside if we do it in the way the PREOXI trial actually mentions. So I'll start there. Do you think ventilators should be present at all non-crash intubations before you start? And then I'll ask a follow-up question. Whoever wants to start with it.
Yeah, I'll start and I'll give, the ED perspective because I think that really anchors on that. Obviously, we intubate wherever in the emergency department when setting dependent, we have ventilators in our resuscitation rooms, but intubate all over the department. I would say that a couple of things. One, it's really important that people recognize that the most standard ventilators will be able to deliver non-invasive ventilation in BiPAP mode without having to bring in separate BiPAP machine. That was a key feature for the emergency departments that are enrolled in the study. And we're not bringing in two pieces of equipment. You're able to have, one ventilator typically. Sometimes there's a software need. Sometimes there's an adapter need, and then transition straight to mechanical ventilation. The question is, in a time-sensitive circumstance, if you don't have a ventilator there, what do you do? And I think the answer is, and this occurred in the trial in patients enrolled, is use the bag valve mask with ventilation, if you're following the protocol in the PREOXI trial, without the ventilator until the ventilator arrives, depending on the timing, or just continue to bag the patient after induction prior to laryngoscopy, prove that positive pressure. It wasn't the optimal way to implement the intervention, but that was a way you could administer the intervention in the positive pressure group in the PREOXI trial.
I think one of the things I really like about talking with ED physicians is how different our experiences are. So I was trying to think back while it was talking. I'm not sure I've ever intubated a non-emergent airway or a non-crashing airway without having a ventilator at the left. And I think I think that in most ICU intubations, you have the time to gather equipment and supplies, and you're in a much more prescribed location than you are in the craziness of the emergency department where 1,000 things are happening at once. I genuinely think that most ICU non-code airways should occur with the ventilator.
Yeah, I think it's the practical nature of the real world implementation of this, both in the trial and now with the trial results in hand. And you have a crash airway, you're not going to wait, obviously, and say, oh, wait, Preoxy said I need to preoxygenate with positive pressure for 3 minutes. And in fact, those patients were not enrolled in the trial. So we can't even generalize this trial results to the truly crash airway because you needed at least a little bit of time, couple minutes to randomize and start implementing the intervention. But in other cases, you can implement the positive pressure intervention in a pragmatic way, whether or not you have a ventilator there.
And you might be saying the same thing as me, but I really want to clarify. I don't think providing BVM ventilation gets you anywhere near what the trial was offering. I think strapping a BVM mask to a patient's face with a PEEP valve, preferentially with a nasal cannula underneath to give an actual pressurization of that PEEP valve, that would duplicate near exactly, in my mind, the true benefits of the trial. Is that what you're referring to? Because okay, fantastic.
Great point. Yeah, so absolutely trying to do optimal BVM with the PEEP valve. We didn't have a strong opinion on the use of nasal cannula in the trial, but it was definitely quite common. There was different opinions on the seal with the BiPAP mask in particular issues. So it certainly occurred, but we allowed that to the provider discretion. It's well represented in the intervention group, whether it was using the BiPAP mode on the ventilator or BVM, ideally with the PEEP valve. So either way. But yeah, I think trying to do the best you can with the equipment that you have available is definitely the message.
And so what did I not notice about the trial and the other readers that you two have pieced out as a really important finding that might not immediately jump off the page?
I think a key feature from my standpoint is the obesity finding, which clearly all patients appeared to have benefit. If you look at the forest plot in the paper, regardless of starting FiO2 or the level of hypoxemia, regardless of location, ED or ICU, patients were benefiting from prevention of hypoxemia across the board. Really stood out is the obese patients, as you might expect, especially with a ventilation intervention, certainly a positive pressure intervention, that there was particular benefit in that subgroup. And I think that is certainly a key feature. We know clinically that those patients are at high risk for early desaturation. With the intervention and preoxy, their level of risk for hypoxemia essentially were down to non-obese patient type levels. I think it's really...
Yeah, I think for me, it's really twofold. And this study demonstrates that administration of both pre-induction CPAP and positive pressure, post-induction apneic breaths in the emergency department is safe and does not increase the risk of aspiration. In fact, in the 2 largest trials of positive pressure ventilation post-induction to date, there's been no association between aspiration and positive pressure ventilation. And the second is that this intervention seems to reduce, or at least is associated with the reduction in the risk of cardiac arrest. And I think that's obviously that's something we want to avoid with dermal airways, but this is the first intervention that has demonstrated to make a difference in that. I think that's pretty important.
All right. Now, neither of you truly have a magic wand to affect what is standard care, but let's say I gave you one. Each of you have that wand. Going forward after this trial, what would you dictate as this should be standard care from this point forward? I'll start with you, Adit.
Yeah, I think we're already having these discussions at our institutions that participated in these trials. Our health system is already preparing to implement these trial results across emergency departments and ICUs, and essentially being prepared. There's preparation, equipment, training, getting respiratory therapy involved to just make this the common practice that we will use non-invasive ventilation with the ventilator that will be used ultimately to provide invasive mechanical ventilation after intubation. Be ready. There's some technical components to make sure that people are comfortable using BiPAP mode and the settings and making sure the equipment is there. So just be ready. This is just part of our normal practice plans for intubating patients when possible, when available. Again, we're flexible people in the emergency departments and in ICUs as well. Just be ready to pre-oxygenate when you have the time in this way. Give it a few minutes, get your equipment ready, and then continue positive pressure ventilation after induction, and then be ready to intubate, hopefully with more time and with less risk.
Yeah. So for me, I think if I had the magic wand, I would broadly implement this across intubations and in ICU space. And the reason is that I think, at least me, and I think most clinicians are bad at predicting who is at risk for hypoxia. If you look at this trial, patients who were intubated from room air, so who were on room air prior to preoxygenation, non-invasive preoxygenation reduced the risk of hypoxemia in that patient population. So I don't think it makes sense to restrict this to obese patients who are presenting with ARDS. I think generally we should be applying this intervention to reduce the risk of complications in patients who have been intubated broadly.
Yeah, I couldn't agree more. That I have been preaching pretty much exactly what you folks had done in the trial for about 15 years now. And this is finally, I think, the crucial evidence that now will say that this is not just opinion anymore. I think this is the best possible evidence we have for how to go about this. And I agree with you, Kevin. I don't think this is restricted to a patient population other than the restriction to a critical care intubation rather than extrapolating this to an elective case in the OR. But I think any patient who is actually being intubated because they are sick would benefit from this. And I think it's pretty much it's a no-brainer. I love, Adit, what you had said about this might lead more EDs to have the ventilator that the patient will eventually use at the bedside, which I think is beneficial on a number of levels beyond even what this trial has. I think it's abhorrent, a situation where you're bagging for 15 minutes waiting for respiratory to finally bring a vent. It's laughable. I think for EDs that still is going to be a problem. The capability of doing this with a system that doesn't require a machine, you could get a very similar thing just by buying mask straps and using a BVM with a PEEP valve. And I'm still absolutely, I really feel that without a nasal cannula, based on the research we have done with volunteers, that you just don't get the provision of CPAP. It's not for apneic oxygenation. It's not for anything beyond the fact that the system just doesn't work between breaths without something giving a continuous flow and pressure to make it from a low flow CPAP to a high flow CPAP. But I think your trial results could be implemented tomorrow in every ED and ICU across the country without too much fanfare or misery. And I think patients are going to benefit as a result. So I just want to commend you two again and all of the people on your trial group for making this happen. I think it's an enormous accomplishment and it's so potent for the space of resuscitative medicine. So what question should I have asked either of you that I didn't, that you want to get out there?
So I was really anticipating a high flow nasal oxygen question.
I'll tell you my feelings on that. I don't think it brings anything to the table over the provision of a true titrated non-invasive preoxygenation strategy. I think you're just losing out on all quantitation. You really don't know what you're getting with that. And being someone that is providing a high flow nasal cannula, the standard nasal cannula throughout all my intubations, I just don't think it brings much. And that is a situation where I worry about a mask seal with the larger cannula sizes of a high flow. So yeah, I've never been a big proponent of the whole florali, all of that path that the anesthesiologist went down. I'm not sure what it's bringing to the table. And I'm curious to hear what you two think about that, because it was present at some small level in the trial, but it seems like your paper may be what knocks that off of having high flow as a preoxygenation strategy. It's one of the most fantastic non-invasive strategies for many of my patients with respiratory distress, but for me, it's not a great preox tool.
Yeah, I'll go first and then Dick can take us home on that one. But I think the point you made at the end is very important. When I'm not intubating someone, you can rip the high flow nasal cannula from my cold dead hand. Because in the context of it, preoxygenation, it's unclear to me if physiologically it's any different from flush rate, non-rebreather. And it's another device you have to set up. It impairs your non-invasive seal. And I personally don't see a real role for it. I don't know, if you have anything?
Yeah, I think we have consensus in this group. We could have done a trial with heated high flow nasal oxygen as a group, as a comparison group. And we get questions, great, non-invasive ventilation is strongly beneficial. Can't we just use the heated high flow nasal cannula? And we're not pursuing that as a next step study. We're not planning to compare non-invasive ventilation or BiPAP to heated high flow nasal cannula because we feel like, as you said, this is the optimal way to implement the intervention as described in PREOXI, and we didn't include it in the trial as an arm for that reason, because we thought it would be fairly similar to the flush rate face mask oxygen group.
As soon as it became acceptable to bag during the apnea period, or in your case, let the machine do the bagging for you during the apnea period, I think it blew high flow nasal cannula in a preoxygenation setting out of the water. The only thing it really brought to the table is the most effective form of apneic oxygenation. And you'll never have found a bigger proponent of apneic oxygenation until apneic ventilation became okay. And then I don't really care about apneic oxygenation at all anymore. And I think this trial proves that. So I think we're done with high flow as a preox tool for anything outside the operating room. And even there, I don't know why they're doing it. So what's next?
Right. So we have a number of exciting trials that are ongoing and preparing to start. I'll take the easy answer and talk about the pragmatic trial that Ed and I are both participating in now, which I think is probably near and dear to the emergency department heart, is that we are both sites in an RSI study of ketamine versus etomidate, which is going to be the largest emergency tracheal intubation study to date, probably going to definitively answer that question in terms of mortality.
Love it.
So that's very exciting.
So we're looking at every stage of the process. We've looked at in the device trial from last year, video versus direct laryngoscopy. As Kevin mentioned, ketamine versus etomidate. Okay, fine. What about paralytics? We're planning a depolarizing versus non-depolarizing neuromuscular blockade trial that should launch very soon. All right, video laryngoscopy, hyperang versus standard angulation. That's planned in the works. Different populations. The ketamine etomidate trial is not in trauma patients. Most of our trials include both, but we're planning for that as well. And then post-intubation management is also on the table as well. So we're really trying to pick apart these key fundamental sort of existential questions in airway management and try to make this procedure as safe and effective as possible.
So excited to see what's coming out. Lovely. All right. I can't thank you gentlemen enough. And I am so happy you're out there doing this work because it's really wonderful to see fantastic and large airway trials finally coming out.
Awesome. Well, I enjoyed talking about it. Thank you for your dissemination help and look forward to hearing the podcast too.
All right.
Yeah, definitely. Tune in to the Critical Care Reviews presentation if you're up at 6 a.m. Eastern time. It's 4 a.m. time, but Kevin and I will be in Belfast. And
Sounds
Kevin
good.
will be primarily in the hot seat.
All right. Fantastic. All right, so now that we've heard the amazing commentary from Kevin and Adit, let's talk a little bit about the trial and then go into some recommendations. So this was a pragmatic trial, and that means you're not really going to get the explanatory benefit of knowing what each piece actually contributed. You're not going to have this perfect, pristine lab of comparison between the intervention and the comparison. Things get a little messy, but it better reflects what happens in the real world. Now, that being said, in pragmatic trials in general, you're going to have a minimal amount of prescriptive intervention. So in this case, it was just the recommendation to do the non-invasive positive pressure versus the recommendation of doing a non-rebreather face mask. And then whatever happened, which is fine. I got no problem with that in pragmatic trials. Now, the minor quibble, and I say these are minor quibbles because this trial was extraordinarily well done, so well executed, so beautiful, and so important. But if I had a quibble, I'd say it's going to be on the descriptive end, because there were things that the research associate who was there asking questions after the intubation could have actually asked to have a descriptive representation of what happened. And the two I really, really wish were there. And the number one primary one that I would have liked them to ask is, what flow rate was the patient preoxygenated on their non-rebreather mask in the standard care group? That would have been an incredibly important piece of information that would have taken one question to get, and we would have had a real understanding of how much FiO2 played a part in the difference between the two groups. Now, I was really reassured from Kevin and Adit's answers on this that the standard group did indeed get excellent FiO2 preoxygenation. I feel pretty good about that, but I would have felt even better if we had a chart line that said number of patients getting greater than 50 liters by their non-rebreather. That would have been great. Number two was whether or not there was a PEEP valve turned to something representative of reasonable PEEP on the BVMs in the standard group. That also would have been something I really would have loved to know, and it could have just been an easy question asked of, did a PEEP valve appear on that BVM? If so, what setting was it on? That would have been very utile to make inferences for future trials and to see really what the differences were that were provided in that bundle of care from the standard group. But as I said, these are minor quibbles. This study is a real high mark for the performance of airway trials. It is fantastic. All right, let's go into some recommendations. Now, the doubters will say that the difference between these two groups is indeed the FiO2 provided between the two groups. And they're going to say that in the non-invasive group, the major difference was they were getting 100% FiO2, while in the standard care group, they're going to pretend that all these patients got 15 liters per minute, and therefore they were getting 60% FiO2 preoxygenation. That's the whole difference, and we shouldn't change our practice to actually provide positive pressure and increase mean airway pressure during the preoxygenation and induction period. They're going to say it doesn't matter. I could not disagree more. I already felt pretty reassured just by reading the trial. And then after I talked to Kevin and Adit, I feel much, much better to say that no, if that had any part, it was a minor piece of this. It is indeed the increased mean airway pressure during the preoxygenation, and then the combination of increased mean airway pressure and the provision of apneic breaths during the apneic period that made the major difference in that trial. That's where I'll put my money down on this, and it's not the difference in FiO2 between the two groups during the preoxygenation period. Number two, and Kevin made this point, but I really want to emphasize it, even patients on room air had a benefit from the non-invasive positive pressure preoxygenation and maintenance of apneic CPAP. So even the patients you say, maybe I'll do this on the super sick patients who are already hypoxemic, but I'm not going to do it on the regular players. I don't think you have the data to support that. I think the data from this trial will tell you that all comers who are critically ill should be getting non-invasive positive pressure ventilation during their preoxygenation and apneic period. Now, what does that mean? What's the take home from this? It means that if you had an intubation similar to an elective OR case, and we have these sometimes in the ED, a patient, for instance, you're intubating because they have an esophageal foreign body. They have no lung issues at all. They're not critically ill. You're just protecting their airway for the endoscopy. All right. If you don't want to do this, no problem. Or similarly, a patient who is a pure airway issue. You could argue, okay, well, this is not applicable, right? Like a patient who you're intubating just for a angioedema, for instance. But I would say even in those patients, it's just easier to make one thing you do for all patients. And I think it should be this. I think this should be how you manage intubations in the ED and ICU from this point going forward. Now, even if you don't buy into that, well, I think it's mandatory now for obese patients. We've always known that obese preoxygenation without increased mean airway pressure, without PEEP or CPAP, is a failure because they are already atelectatic, already at below zero, simply from the weight of their chest wall and the abdominal contents pushing up. So those patients, it's mandatory, but I would say my take is any critically ill patient being intubated in the ED or ICU should get some form of preoxy surrogate one way or another. And we'll go in just a second about what that means. Number two, I guess I'll encompass all that in number one. I don't know. Second thought, there should be non-invasive positive pressure masks at every location, ED and ICU. You should just have these. It shouldn't be wait for respiratory to bring a non-invasive mask along with a non-invasive machine. The masks themselves in multiple sizes should be present in the ED or ICU already because they're now no longer just for a patient you're putting on to BiPAP. It is for any patient who's going to get intubated as well, which means you can't wait, which means they should be present at the bedside. Now, if you can't make that happen, then get mask straps, which are, I don't know if you've ever seen these. They're like X-shaped straps. They go behind the patient's head and 4 little tentacles emerge. And they come with a little plastic device that goes over the 22 millimeter connector on your BVM mask. And now you could strap a regular BVM mask to the patient's face. And it just becomes, in essence, a non-invasive mask. They use these all the time in anesthesia. I always kept these around because it let me take any mask from a BVM and make it into a non-invasive mask. So one of those two, either standard non-invasive masks or mask straps and prongs to take a BVM mask and make it into a non-invasive mask, should be present in every ED and ICU. Next up, you should be doing superlative preoxygenation, which post-preoxy means one of these 4 things. You could use a CPAP mode on a ventilator or a BiPAP machine and then switch them after induction to something like a standard ventilatory mode, for instance, a volume mode, like a volume assist control, and then put them on settings that are going to get them both PEEP and positive breaths during the intubation. They went with 10 in preoxy. I don't think it really matters. Anything more than 2 to 4 is getting you where you need to go. If you feel the patient's a little bit higher risk and you just want to stick with 4 to 6 breaths, that's fine. There's not going to have any oxygenation difference. You just need greater than the bare minimum, which is somewhere around 250 mLs per minute of oxygen provided to get the job done. So, even lower than the 10, you're going to do just fine. But this study, PREOXI, if it did nothing else, and it did plenty else, if it did nothing else, it proved that giving 10 breaths a minute during the post-induction period is absolutely safe. So something that provides them a respiratory rate and PEEP will satisfy PREOXI. Now, if you want to go with the pure PREOXI protocol, then just put them on a non-invasive mode with breaths, with both inspiratory and expiratory pressure. And then during the apneic period, post-induction, you don't have to change the mode. That was Kevin's point of why they actually recommended that. I don't know. I think it's a little bit more elegant to have them on just CPAP in the preoxygenation period and then turn them to a mode, but that requires an additional step. So if you're not willing to do that step, if you don't know how to work the vent as well, if you don't want to deal with it, if you're worried about forgetting, then just go with what they did and put them on inspiratory pressure, expiratory pressure, and a backup rate during the preoxygenation phase so that it will continue as soon as you induce the patient. Now, number 3 option, you could use an oxylator. If you don't know what that is, just search for oxylator, Oxylator on EMCrit, and you'll find the podcast I did on it. But the oxylator, which I already love, actually now, post-preoxy, takes a real predominance in, I think, a way of getting this in an easy fashion that doesn't require a vent at every bedside. I think there should be a vent at every bedside in a resus bay of an ED. They should just be there. And I disagree with Adit on this one. I don't think you should be intubating anywhere in your department. I think you're better off bagging the patient and bringing them to your resus bay where all of the difficult airway equipment should live. So I would say vents should be there. Vents should be in the ICU, in every ICU bed. And Therefore, you don't have to worry about it. But if you couldn't make that happen, oxylators are fantastic at this with a PEEP valve. An oxylator plus a PEEP valve will get you perfect preoxygenation, and apneic ventilation, exactly how you want it. Oxylator plus a PEEP valve, golden, gorgeous. Or BVM plus nasal cannula plus a PEEP valve with a non-invasive mask. This is the key. Non-invasive mask, BVM, PEEP valve with a nasal cannula underneath. Now, first, why non-invasive mask? Because it's really a pain in the butt for 3 minutes to hold a mask on the patient's face. You have a tendency, you look up or you're getting stuff ready and you hold it with one hand. And now they take some breaths that are at ZEEP, 0, PEEP, and at room air. It doesn't work as well. It's not going to get it. You want a tight-fitting mask. So that means either a non-invasive mask, and the BVMs will just hook right up to that. You just take off the BVM mask, you save it. You want to have that standing by at the bedside, but you just hook the BVM up to that non-invasive mask with a PEEP valve with a nasal cannula underneath, or a BVM mask with mask straps, which also works wonderfully. And the same thing for the oxylator, non-invasive mask or a standard BVM mask with mask straps. Now, why a nasal cannula? I mentioned this numerous times during the podcast, and let me explain why. And look, if you've listened to EMCrit for any period of time and heard my preoxygenation lectures, you've already known this. But if you just hold a BVM with a PEEP valve over a patient's face, that is low flow CPAP, which means, in essence, if there's any leak or any uptake of oxygen by apneic oxygenation, they actually lose that mean airway pressure increase. They lose the ability to get the full benefits of this. If you have a nasal cannula underneath at something like 10, 15, or much higher if you want, Nick Caputo's work showed that was safe. But 10 or 15, you're not even doing it for the apneic oxygenation. You're doing it because it provides pressurization of the PEEP valve. So now it's a leak-tolerant device, which the non-invasive mode on a vent is as well. That's why, and that's so important. But it's a leak-tolerant device now. There's a continuous flow that will pressurize that mask regardless of whether there was a small leak or regardless of whether there was an uptake of oxygen. That's why the nasal cannula should be there. Now, my belief is on any of these 4 options, you should probably just have the nasal cannula there at 10 to 15 liters per minute. It's not going to hurt anything. The standard nasal cannula does not affect the mask seal. You can find that study on the link I'll show you at the end of this podcast. But I think a nasal cannula should be there on all of them. It's just an additional benefit for no loss. But certainly with the BVM and a PEEP valve, because otherwise you're reliant on a perfect seal, and you never get that perfect seal to maintain that PEEP between breaths, and the patient will not have a continuous source of high FiO2 oxygen. So nasal cannula plus BVM plus PEEP valve on a non-invasive mask or a BVM mask with mask straps will get you everywhere you need to go in preoxy. And then when they actually become apneic after you induce, then you just need to bag them. And you bag them if you want to go with the preoxy 10 times a minute. I personally would say 4 to 6 is more than ample to get you everything you want, unless the patient has a metabolic acidosis that you're compensating for. Now, I have developed the EMCrit BVM, and that should be coming out in the next 6 months or so. That obviates the need for a nasal cannula. It is a high-flow device without a nasal cannula. And so look for that on the horizon. As soon as that's out, I will tell you. All right, another point. They excluded patients who providers felt had too much of an aspiration risk to put them on non-invasive. So those were excluded. So now what does that mean to you? It means that if you have a patient who is not a full stomach, because all ED and ICU intubations ostensibly are full stomachs, but a full stomach, by which I mean something like a small bowel obstruction where the patient's already been vomiting, or a massive upper GI bleed. But even in those cases, I have a tendency to put down a nasal gastric tube before the intubation and suck all that out. Or if they won't allow me to, actually do a delayed sequence intubation and actually give them the ketamine to allow a nasogastric tube to get put in. But if that's not the case, I still think it's very safe to preoxygenate them with PEEP. I probably wouldn't give them the inspiratory pressure at that point. I'd just give them PEEP along with their high FiO2. And then during the apneic period, maintain apneic PEEP or CPAP. Don't give them positive pressure breaths, and have the nasal cannula there to allow for apneic oxygenation. And I think then you're still getting most of the benefits without having to give them positive pressure breaths during the apneic period. So since those patients are excluded, we can't really speak to them, but I think that's what I would do. Now, we talked about this during the discussion period, but I think high flow nasal cannula, high flow NC is out for preoxygenation for critically ill patients. I just don't think it brings anything to the table versus actually putting them on non-invasive. And I would say even if you had them on that and then they failed and you want to now intubate them, I probably would switch them to true non-invasive, or like I said, a BVM with a PEEP valve. I think that's the better way to go. Now, you could ostensibly leave that on underneath those things, but I do find that bulky cannulas do prevent mass seal, so I might consider turning that to a standard nasal cannula. All right, I've said a lot. I can't believe I got the privilege of being able to look at this before it was even published and therefore talk to the authors and have this ready to go, hot off the press. This is a practice-changing paper. This is remarkably important, and it really validates work that I have been speaking about for the past 15 years. I've been recommending this ever since Rich Levitan and I published our first review paper on preoxygenation in the Annals of Emergency Medicine, and I am so happy to see it proven, I think, beyond a shadow of a doubt. So thank you to all the authors of the PREOXI trial. Thank you to Kevin and Adit for coming on. Thank you to the Department of Defense for funding this and making it possible. Thank you all for listening. I can't wait to hear your comments in the show notes for this episode. You could also check out the EMCrit Preoxygenation page that has so many studies on all of this work on preoxygenation that I've been accumulating over the past 15 years. So you can find that at emcrit.org/preox. That's emcrit.org/preox. And this has been Scott Weingart for the EMCrit podcast saying bye-bye.